My talk was about early stage disease, so primary triple negative breast cancers. And at the moment, immunotherapy, or specifically PD-1, PD-L1 inhibitors, are not approved for the use in the early stage setting. And I agree with that. They should not be routinely used. The data so far is only short-term data with a neoadjuvant PCR endpoint, and we're not sure how this PCR endpoint will translate into long-term survival differences. If they do, it's quite possible that they will, but we don't know that at the moment. There was a statistically significant increase in PCR rates in 2 of the larger phase 3 studies, but we don't know how changes in PCR will mediate changes in event-free survival in the setting of PD-1, PD-L1 inhibition. So at the moment, we don't routinely use it. I would strongly encourage clinical trial participation. And also the other significant issue is the possibility of lifelong immune AEs, immune side effects, in particular thyroid dysfunction, which occurs in around 20% of patients. We think this is potentially lifelong. And there are also some severe side effects, such as the development of diabetes, for example, or neurological disorders. And this is in a population that's highly curable. And as yet, we don't understand the impact of these agents on fertility as well. So we need longer term data before we can use these agents in this setting. In other tumour types, there is more adjuvant use as opposed to neoadjuvant use. But we have some information from the preclinical setting where they evaluated the neoadjuvant approach, so giving these agents when the tumour is in situ compared with giving these agents when you remove the tumour, so to eradicate micrometastatic disease. And it does seem that the immunotherapy does work better in mouse models with regards to improving survival if you give the immunotherapy in the setting of tumour. And so this was because as the tumour breaks down, there's more antigen presentation, there's more T cells being generated, and this seemed to occur better when the tumour was in situ. So we only have data from preclinical models. I mean, it does make sense because, you do have tumour breakdown, you have antigen presentation, you potentially have increasing repertoire of your T cells, you have T cell expansion. And then you remove the tumour at surgery so you don't have as much exhaustion of the T cells, and they become memory T cells to protect against future challenge. So it's plausible, and we'll wait and see whether this pans out in the longer term. Of course, we don't have a study where we're comparing neoadjuvant versus adjuvant. We just have studies where there is neoadjuvant and then an adjuvant phase, and also adjuvant studies as well. And then we also have the post-neoadjuvant setting as well. I mean, from a personal point of view, I do believe that we give probably the chemotherapy that's not optimal for immunotherapy. So it is possible that once we give all that chemotherapy and we're giving immunotherapy post-chemotherapy, that's not the best place, because we've done a lot of damage to one's bone marrow with regards to lymphopenia. So it's possible that can also impact on the efficacy of these agents in the adjuvant setting.